Our next speaker, first time presenter with us here in Reading, is Dr. Jonathan Purnell. He's professor of medicine at Oregon Health Science University in Portland, Oregon, with board certification in both endocrinology and obesity medicine. His research interests include understanding the causes and consequences of obesity, dyslipidemia, and diabetes in humans. He's the director of Oregon Health and Science University Knight Cardiovascular Institute Center for Preventive Cardiology, which integrates management of obesity, lipids, and diabetes to prevent cardiovascular disease. He's the co-editor of the obesity section of the online textbook EndoText. He is the assistant editor for Diabetes Care and the Journal of Lipid Research and president-elect of the Obesity Society. Please welcome Dr. Purnell. Thank you for coming.
Oh, sure. Nice to meet you.
You too.
I think I need this one. All right.
Thank you.
Thank you, Dr. Khan. Very nice to meet you. Good to be here today. I think it could have, I was telling the driver when I was coming in, I probably could have driven down here in the same amount of time as it took me to fly from Portland to San Francisco and over here. The flight was very nice, though. Thank you. I have the pleasure of talking today about mitigating risk in patients with type 2 diabetes, a topic that's near and dear to my heart. Let's see if I can get this thing to roll. Should be got it. These are my disclosures. And the two aims today are to understand that when diabetes is present, it basically acts as a cardiovascular risk accelerant. So making decisions about what we choose and how we do manage diabetes should have that first and foremost in our mind. And then to review the existing and some more recent trials that tie together the risk for cardiovascular disease in patients with diabetes along with kidney disease. Because as you probably are becoming more and more aware, we're coming to understand that actually when we talk about diabetes, when we talk about kidney disease, when we talk about cardiovascular disease, we're kind of like proverbial men and women around the elephant. We really are talking about that plus what's now called MASH or MASLD, metabolic dysfunction associated liver disease. And also I would throw in there HFpEF as well as sleep apnea. So these are things we should all be aware of, but I want to point out that some of the more recent trials have started to really link not just chronic kidney disease in the form of low eGFR, but also proteinuria with that risk factor. So as an endocrinologist, I started my career some almost 40 years ago now with the data that came out of the diabetes control and complications trial, where we understood that when we're managing hyperglycemia in patients, we're really trying to manage the complications of that hyperglycemia once they, it comes down into a range that are no longer spilling over in their urine. So historically, that's been microvascular complications, and the big ones for that are eyes and kidneys and nerves. And the threshold for that has always been less than 7%, and that came from a type 1 population. But if we're honest about it, macrovascular complications are why people actually pass with diabetes. Heart attacks, strokes, and other vascular issues are the leading causes of morbidity and mortality. So I would say that when we're talking about managing diabetes, we should really be putting our money on the macrovascular outcomes, and I think the microvascular will follow from that. This is the data that I like to show that talks about my concept of diabetes as a risk accelerant. Whatever patient you have, just think of having diabetes as doubling their cardiovascular mortality. And so if you don't have any pre-existing heart disease or stroke, your mortality is twice normal. If you've had an MI, now you're up to 4 times mortality rates. And if you've had a stroke, now you're up to 8 times mortality rates. So this is an important condition to recognize early and to manage appropriately. The role of CKD is an additional accelerant. This is just data that shows in patients without type 2 diabetes, with diabetes, and with diabetes and chronic kidney disease, you can see at any particular morbidity, just heart failure, acute MI, CV, that having the combination of chronic kidney disease, in this case low eGFR, is also an accelerant, basically doubling whatever they had just with diabetes alone. And the purpose of this slide is to show you that like highly sensitive CRP is a good marker for subclinical active heart disease, microalbuminuria is now being recognized as a very useful tool for tagging people with early kidney disease. And in fact, microalbuminuria can happen in up to 20% of the population anyway. You don't have to have diabetes. It's there in the background probably indicating low-level kidney disease. But it will show up earlier, especially the levels, the threshold we use now is above 30 for urinary albumin to creatinine ratio. And again, if you parse patients out and look at, in this particular case, cardiovascular mortality risk, and looking at patients with diabetes and CKD and microalbuminuria, you'll see that until you get to the very end stages of kidney disease, that microalbuminuria is a marker for even greater risk. So like highly sensitive CRP, which I'm doing a lot more now, as we heard from the previous speaker, I'm also doing urinary albumin to creatinine ratios on all my patients on a regular basis. Turning back to the complications and why we manage them, or what we do for them, historically, as I mentioned before, we've really focused on trying to minimize eye damage, and nerve damage and kidney damage. And pretty much from the data from the DCCT and the UKPDS, getting below 7 really does a good job, gets at least 50% reduction in these outcomes, and historically has been the thing we focused on. You can do that with lifestyle. And pretty much any medication that is currently will lower glucose will get you to that target and will benefit microvascular outcomes. So historically, when we've gone to insurance companies and said, I've got a patient with diabetes, the insurance companies will consider all these medicines equivalent for that purpose of lowering glucose. So they'll just choose whichever one is cheaper for the patients, and so metformin has historically been the reason why we do that. I also want to point out that metabolic bariatric surgery, hands down, by far and away for patients who qualify it, is the best therapy that a patient with diabetes can have, type 1 or type 2, not only in terms of reducing their microvascular risk, but also their macrovascular risk and overall health. And I can certainly talk about that in the question and answer later. But what do we have in our armamentarium? What can we use for patients with type 2 diabetes to lower their macrovascular risk? What does the evidence guide us towards? And just a spoiler, when I get to the medications, it's not what I showed you in the previous slide. But historically, and definitely want to emphasize that there are a number of therapies that we can use to reduce cardiovascular and stroke events. Obviously, traditional cardiovascular risk factors, including smoking, using baby aspirins, ACE inhibitors, icosapent ethyl EPA or Vascepa for patients with triglycerides over 150, and then LDL lowering to achieve historically, which have been LDL levels below 70 is a priori. Type 2 diabetes, even without a history of cardiovascular disease, has been considered a cardiovascular risk equivalent. But getting the LDL down at least less than 70 in patients over 40 years old has been something we've traditionally done. Don't want to forget about those things in terms of treatment. But what about medications to treat the hyperglycemia, the diabetes itself? There are only 3 of the current classes of drugs that we use that have been shown to reduce macrovascular complications. The first is metformin, biguanides. And there are some caveats with that. Stop when it's below EGR below 30 now. And you can use with caution when it's below 45. In the past, we used to stop it because of the idea that patients on metformin who got into stage 3 CKD were at risk for lactic acidosis. That's actually not true, but we still stop it because it's really cleared below EGFR 30s. Now, where's the evidence that the macrovascular benefits of metformin? That comes from the United Kingdom Prospective Diabetes Study. This is a fairly old data now. And in that study, it was only a subgroup of patients with obesity in the UK PDS who actually were treated with metformin. So we're only talking about a couple hundred people total, but they were followed during the trial, and it was the only therapy out of insulin, sulfonylurea, metformin, lifestyle that showed a reduction in cardiovascular acute MI events in that study. And then this is the extension phase, off-label, where they were continued on with whatever the usual care was. And you can see there's a bit of metabolic memory. There's a protection against acute MI and also all-cause death for another 10 years later. So metformin is a good choice in patients as a therapy for glucose control. I have nothing against it, but I'm going to show you some other data here in a minute that, and also talk about the American Diabetes Association guideline changes that have shifted away from that as a first-line agent towards more better evidence medications like GLP-1s and SGLT2 inhibitors. So GLP-1 receptor agonists have been around a long time, despite what a lot of patients will say, well, these are new drugs for weight loss. They're actually not. They've been around. I've been using them, and probably you have been too, for a long time for diabetes. We have a lot of experience with them in that regard. And there's been some recent cardiovascular outcomes trials here that I want to highlight. One's called the SOUL trial, which was used oral semaglutide, and then the SURPASS trial, tirzepatide, as well. And I created this table because this represents all the cardiovascular outcomes trials using a GLP-1 receptor agonist in patients with type 2 diabetes. Oop, looks like it didn't pass the formatting test. I need a fellow or chief resident to help me. I have a number of columns there, how well they do in terms of reducing A1C, which is what everyone really wants to know when you do a diabetes trial. I throw in the weight loss part of it because that's what I have an interest in. But it's that last column there, the 3-point MACE. That's MI, stroke, and death from an MI that really is the primary outcome for these studies. And what you can see is starting with exenatide, then liraglutide, dulaglutide, and semaglutide, that there's a kind of a stepwise improvement in that 3-point MACE up to the semaglutide 1.0 subcutaneous. This is Ozempic 1.0. Now, there hasn't been a cardiovascular outcomes trial with a 2.0 yet. But you can imagine it's got to be at least as good as the 1.0 version. So that's a 26% reduction in 3-point MACE. That's quite good in terms of lowering cardiovascular outcomes. So what I want to point out next is the SURPASS trial, and then the SOUL trial, and then the SURPASS trial. Novo came out with an oral version of semaglutide and Rybelsus, but now they actually they call it oral Ozempic as well. It just was approved for that. And it just published this 9,000 or almost 10,000 participant study where they looked at 3-point MACE and showed about a 14% reduction in 3-point MACE using the oral version of semaglutide, and then a 26% reduction in non-fatal MI. So this was added to the other trials, and compared to the injectable version of semaglutide, not quite as good, but it wasn't also quite as good in terms of lowering A1C or weight loss. So that fits in, though, with but further evidence that the GLP-1s are improving significantly cardiovascular outcomes. The tirzepatide, the SURPASS trial, though, was remarkable, and you have to stay with me on this one a little bit. because this was a non-inferiority study. Everyone has been waiting for the Mounjaro's cardiovascular outcome trial to come out. Mounjaro is superior to Ozempic in terms of weight loss. You're looking at 12 to 13% weight loss instead of 6 to 7% weight loss. Really hoping that that would be beneficial. Lilly, the company that owns tirzepatide, also owns dulaglutide. So they wanted to do a non-inferiority study against Trulicity versus Mounjaro. They were hoping that it would be a superiority study. So a non-inferiority study, you go to the FDA and all you have to say is, well, this isn't worse than dulaglutide, so you can approve it for the indication of cardiovascular disease, because dulaglutide already has an indication for cardiovascular risk reduction. What Lilly, though, did at the same time was they kind of understood that since dulaglutide was already successful and that they may not show superiority to their old drug, they actually got permission to compare it to the placebo of the dulaglutide study. So it's kind of a 2-for-1. You get to compare it to your old drug, but you don't have to recruit a whole other group of placebo to compare them to. So you're just comparing to your old drug. So anyway, when they did the study, what they showed was that the hazards ratio came down about 8%, meaning that Mounjaro outperformed dulaglutide with another 8% reduction in 3-point MACE and improvement in cardiovascular outcomes. But it wasn't significant. So they had to just say that, well, we're as good as dulaglutide. But none of us really wanted to hear that. We were really kind of looking for the other. So I'm going to show you the comparison to the placebo data that was presented at the European Association for the Study of Diabetes meetings last September. And I don't think that they've published this yet. I've been looking for it. I haven't seen it. But just draw your attention to those lower boxes down there. What they are indicating is the data showing the benefit compared to the dulaglutide placebo. So this is now showing a 28% reduction in 3-point MACE and almost a 40% reduction in all-cause mortality. There's very little outside of bariatric surgery that improves all-cause mortality in patients with diabetes and cardiovascular disease. So this is really a significant event to have happen, at least to have that data. And so what I wanted to do is actually, let me go back there, also point out that so this is a formatting problem. That little yellow box should be down 2 rows. So if you just pretend that box is down 2 rows, okay, you'll see that the drop in A1C was 2% with Mounjaro, 15 milligrams. That's a remarkable amount in patients who are coming in with an A1C of around 8% to start with. The weight loss was 12%, I mentioned before. That's a remarkable amount of weight loss. And there's a lot of sort of discussion right now about the weight loss and potentially benefits in cardiovascular risk of the GLP-1s independent of weight. And I think it's important to kind of keep a historic perspective on where we are right now with the amount of weight you get with these weight loss meds for diabetes, because it's never as good as what you get without diabetes. And then using, again, the bariatric surgery literature to really use as your North Star in terms of cardiovascular outcomes, mortality improvements, AFib improvements, heart failure improvements. And what you can see is if you drop the SURPASS trial results as well as the SOUL trial results, you actually kind of fall along a continuum that's quite nice in terms of showing that the more weight loss you get, the better your 3-point MACE, and this is also true for total mortality. And if you want, I can come back and talk about the data we have on no diabetes another time in patients. So in terms of cardiovascular risk, the newer trials are showing the benefits on cardiovascular outcomes with the oral semaglutide version as well as the tirzepatide Mounjaro. And it's fitting nicely with the other data, and again shows more tools you have in your toolbox to treat type 2 diabetes and cardiovascular risk reduction. in turning now to the heart failure with preserved ejection fraction studies, this is a big area coming out. And again, I would contend that if you have someone with heart failure with preserved ejection fraction, it's just another manifestation of another organ of the glucometabolic disruption you see with fatty liver, chronic kidney disease, and type 2 diabetes. And so when they randomize patients with HFpEF to either Mounjaro or to placebo, in this particular case, using a 3-point outcome, heart failure event, time to CV death, or intensification of heart failure meds, there's about a 40% reduction in that 3-point composite. This is better than SGLT2 inhibitors in terms of outcome studies. So really a nice improvement in that regard. We've also seen, I've skipped over some recent data as well from the semaglutide trials. But where I think the money will be going if we want to maximize our cardiometabolic benefit is when patients have both type 2 diabetes as well as chronic kidney disease. In this particular case, these were patients who were enrolled, about 3,500 of them, who either had impaired kidney disease from the standpoint of low EGFR, or modest EGFR reduction with a greater spillage of proteinuria, greater than 300 in their urine. And this particular trial had a composite outcomes, both renal as well as cardiovascular outcomes, as many of these CVOT trials are now going to. And this trial was actually stopped early because of efficacy. So this is the opposite of what happens in a non-inferiority trial. What they showed was that if you were on the semaglutide, there was a delay in progression of CKD in patients with type 2 diabetes. And for those of you who spend a lot of time looking at these studies, and it's probably, if any of you are in here besides the speakers, you'll notice something about this slope with the progression to kidney failure. This is different from the SGLT2 inhibitors. When you see these slopes with SGLT2 inhibitors, they go down, but then they flatten out. So SGLT2 inhibitors are very good with kidney function preservation. I don't want to take anything away from the GLP-1s, at least in this particular study, but semaglutide is delaying the onset rather than necessarily preventing it like SGLT2 inhibitors do. The time to the first major kidney disease event was also diminished, as well as the specific kidney-specific component event. All of these things were found to be significant. So using semaglutide in patients with CKD and type 2 diabetes showed significant benefit on helping to preserve their kidneys. But in the cardiovascular outcomes, they saw a similar type of reductions, 20% in 3-point MACE, 30% reduction in death from any cardiovascular disease, and again, significant improvements in total mortality. And anytime you take a group of patients and you can improve cardiovascular outcomes and total mortality, you really hit on a good medication to use in them. So showing the benefits. Now, this is a big subpopulation table, men, women, old, young, and things like that. I'm pulling out and highlighting here, I think, what the important finding from this table was. This benefit on kidneys and cardiovascular outcomes, as every one of the GLP-1 studies have shown so far, is independent of A1C control. Whether your A1C is high or low, it could go down to 4.9%. You're still getting benefit on kidneys and heart. So what I tell my fellows now and my medical students is, knowing that tirzepatide can take a patient with prediabetes and 94% of the time prevent them from developing type 2 diabetes. So the reduction in progression to type 2 diabetes is 94%. How many of you guys use metformin for prediabetes in your patients? Do you know what the risk reduction is for metformin to progression to type 2 diabetes? It's 28%. You can use a tirzepatide and you can have a 94% reduction in progression to type 2 diabetes. And also now you getting benefit down to below 7%, down into the normal range for cardiovascular events. We're in an era of treating diabetes where in the next 5 to 10 years, we may be going back to just treating type 1 diabetes because you won't see patients with type 2 diabetes. And we're no longer glucose-centric in our treatment outcomes for those who have it. So you don't have to just stop at an A1C below 7%. These medicines work even below that. So that's an important thing for insurance agents. Insurances, when they deny you your use of your SGLT2 inhibitor or your GLP-1 because of that. So what about the SGLT2 inhibitors? Well, we have a lot of evidence. I'm not going to talk about them today, but I want to talk about some recent studies that show the combination works better than either one alone. So in the GLP-1 studies that I showed you, there have been a number of patients who are already on a SGLT2 inhibitor. So this is a meta-analysis of looking at the subpopulations of patients on the GLP-1 trials who were at enrollment on an SGLT2 inhibitor. Again, showing about a 20% improvement on 3-point MACE and about a 28%, 30% reduction in progression of chronic kidney disease when you added a GLP-1 to an SGLT2 inhibitor. Likewise, there are a lot of SGLT2 inhibitor studies that people were on GLP-1s at the start. And when you add an SGLT2 inhibitor to a GLP-1, you don't get as good of MACE reduction, but you get improvements in the better improvements in the CKD progression. But they're still significant. So we are now getting evidence that, yes, you can use both of them and have an additive effect on outcomes. And then finally, I just want to put a plug in for the nonsteroidal mineralocorticoid receptor antagonist, finerenone. This is something that's been studied now for a number of years. And when you do meta-analysis looking at patients with type 2 diabetes, CKD, and albuminuria, and you're taking patients, you can look at their added benefit with the GLP-1s, as we talked about, SGLT2 inhibitors, which I didn't show you, but it's been known, but now throw in finerenone, and you're seeing benefits on 3-point cardiovascular outcomes, heart failure outcomes, cardiovascular death outcomes show continued improvements, as does progression to CKD, as does all-cause mortality. So again, we're looking at an era of diabetes management where we're not paying attention to A1C anymore because it's in the normal range, but we are trying to optimize or maximize longevity, reduce mortality, and cardiovascular outcomes. And I just want to point out that it's been about 3 years now that the American Diabetes Association has not said metformin is a first-line agent. They've said that if you have high risk for cardiovascular disease or existing cardiovascular disease, you should start with evidence-based SGLT2 inhibitor or GLP-1. I would argue that just having type 2 diabetes puts you at high risk. The other, and this is independent, and they say this is independent of A1C. So you don't have to wait until the A1C goes above 7% to add this in. You can do it even if they have a 5.7% A1C. And combination therapy works that way too. And the other indication by the American Diabetes Association for treatment, first-line therapy for diabetes, is weight management. And we know that 80% of patients with type 2 are overweight or have obesity. So again, you're only looking, if you wanted to be very selective, at 20% of your population who, you could still argue they're at high risk for heart disease, but you would not want to use that. In patients who are in the normal weight category, I go for the oral GLP-1s because they're not as impactful on weight, but the evidence has for cardiovascular outcomes. So in summary, we know cardiorenal events are the leading cause of mortality in type 2 diabetes. Only 3 drugs, metformin, GLP-1s, and SGLT2 inhibitors, and I will say finerenone in patients with kidney disease have been shown to improve cardiovascular outcomes and mortality. If I have a patient who comes to me in the preventive cardiology clinic with diabetes and they're on a DPP-4 inhibitor, if they're on a sulfonylurea, if they're on insulin and they're type 2, I will take the year and go through them and get them off of those meds and get them onto these in that regard. And we will have to fight the insurance companies on that too. So treating high cardiovascular risk delays CKD. Treating CKD reduces cardiovascular risk and also HFpEF. So I typically would recommend for anyone, start with an SGLT2 inhibitor or GLP-1. I don't mind metformin. It's just it's hard to take for a lot of patients, even though GLP-1s have their own set of issues. But I think the outcomes data definitely favors SGLT2 inhibitors and GLP-1s. And this should be the norm. And that we should not be focusing on A1C when we're making these decisions anymore. If it's below 7%, we should be making them for the patient's interest. So thank you.
Questions?
So the question is the finerenone and who do we place on it? Those are the patients who have CKD or albuminuria with type 2 diabetes. And they're especially when the CKD is progressing. So if I see the eGFR dropping, I'll throw it on top. I use it as a third line agent right now. Five. Yeah. Yeah.
I feel like it's sometimes helpful or harmful in a way that medications, you don't always know, like, should we target like a GFR of 50 or a GFR of 60? Or
Yeah.
is it just showing downward trend of the GFR?
So the question, if I understand you correctly, is there an optimum time to jump in? And then is there a target or some sort of... So it's a very good question. That's why we're recommending screening for microalbuminuria, because that will precede the actual decline in eGFR in most patients. So once they have microalbuminuria, we're treating them. And if they're starting to show a decrease in the eGFR, and I will, or if I get them at a time where they're on stage 3, typically we get them at a stage 3 when we see them. And they're not on it, I'll put them on an SGLT2 inhibitor right away. Because in my opinion, that flattening of the eGFR happens. I've never seen eGFR go back up. So there's no target you want. You just want to prevent it from getting worse, in my opinion. And then we'll throw in the GLP-1 for other reasons. But in my mind, maximum, if someone's showing a stage 3 CKD, I'm going to pull out all the plugs because I don't want them to progress.
We have a question here.
I was curious, you said you recommend bariatric surgeries for diabetes type 1 and 2.
Yes.
And diabetes for type 2 can reverse it. What does it do for type 1 beyond the cardiovascular?
So with the patients with type 1, if it's not known already, the incidence of obesity is the same as the general population. So it turns out that when you kind of normalize your glucose with the newer with the newer treatment options, basically it allows what we think is a genetic predisposition for weight gain to occur, so obesity happens. We don't have any long-term outcome studies in type 1 in terms of cardiovascular risk like we do with type 2. There's about a 40% reduction in total all-cause mortality. There's about a 30% reduction in CVOT in type 2. So I am taking the data from the type 2 and extrapolating it to type 1. So if that answers your question. I'm happy to give you more details, but
Rich?
Yeah.
Are there any data about use of GLP-1s in non-diabetic patients to reduce cardiovascular?
so it depends on what you call non-obese.
Well, not overweight. Let's say non-overweight.
Depends on what you mean by non-overweight. And what I mean by that is that, those of us who are in the society is trying to help, understand what is obesity. we agree that the BMI is not perfect. But I would submit, since this is a cardiology audience, that LDL is not perfect either. There are a lot of different species of lipoprotein particles. We know it's not the only risk factors we heard contributing to heart disease, and yet it still remains the American Heart Association target for both outcomes as well as management as therapy. But to get to your point, the reason why I said that is because we now think of high waist circumference with a normal BMI as being central adiposity. South and Southeast Asian populations are indicative of this type of phenotype. And if you look at the SELECT trial, which was all patients without diabetes but had obesity, or at least a BMI of 27 or higher in that regard, the Asian population of around the world where they recruited people for did the best in terms of the cardiovascular outcomes. They also had the demonstrable improvement in highly sensitive CRP as well. So we're thinking that in the patients who have the high waist circumference, even if they have a BMI of say 25, that that probably group would still be amenable or a target for these. And there are studies that are coming out in the next few years out of China that probably will answer that question in that population. But other than that, all we know is 27 or higher right now is a secondary prevention. That's the data we have that's been published.
Yeah, maybe I'll rephrase it.
Okay.
Skinny diabetic. Because we measure waist circumference in everybody, right? So in somebody that has a perfect waist circumference,
Yeah.
I mean, obviously there's compelling data that GLP-1 reduced cardiovascular events.
Yeah.
The question is whether that's just cardiometabolic vis-a-vis adiposity and all the downstream, or whether
Yeah.
there's some other effects of GLP-1 independent of the
Right.
adiposity-related effects.
Right. And I don't have the answer to your first question, but I would say that when we're seeing, and the SELECT trial did do the waist circumference versus BMI as a predictor of outcomes and showed that change in BMI in patients without diabetes did not predict the improvement in cardiovascular risk, but the change in waist circumference did. But I would say that we categorize obesity as being whole body adiposity, BMI, regional adiposity, visceral adiposity, and ectopic adiposity. So when people lose fat from their liver, when they lose fat from their muscle, when they lose fat from their pancreas during the treatment with these drugs, we consider that kind of a weight loss effect as well. But I know it's an academic thing, but it's, I think, very important as we move forward that we have that sort of information. And to me, one of the revolutions we'll need in managing patients with cardiovascular risk, with diabetes and without, is better imaging tools to understand where the fat resides, how much it's there, and what our therapies do for it in terms of outcomes before we really understand the weight-independent effects of these drugs.
One more.
How about type 2 diabetics that are on dialysis?
I don't know that we have data on that with these drugs. I mean, the SGLT2 inhibitors were never used in that level, and the GLP-1s, I'm not aware of any data in that range. That's a very, very high risk though category. It's almost untouchable. Sorry.
Two questions. One of them is there a new disease entity called cardiovascular kidney metabolic syndrome?
Yes. It's what we call, it's the same thing we've always been treating, but it's taking it out of its silo. So the question is there a new thing called, I think, cardiometabolic kidney disease? Yeah. So that's why I was saying the proverbial blind men and women around the elephant. In my view, where I trained, I started off as a lipid clinic. But we had to know diabetes or insulin resistance because until you know diabetes and insulin resistance, you don't understand dyslipidemia of diabetes. It's not an LDL disorder, it's a VLDL and triglyceride disorder. But if you understand diabetes, you have to understand obesity. So, because visceral adiposity and hepatic fat are the greatest drivers of diabetes and dyslipidemia and things like that. So we've always treated it as being a single entity. We're just, again, siloed in our different areas. The hepatologists have been treating MASH. The patients with the diabetologists have been treating diabetes. The cardiovascular folks have been treating, the heart. But there have been a number of people, a number of thought leaders who are trying to unify this so that other people understand that these physiologies are all integrated. So it's, we call it preventive cardiology at OHSU, could call it cardiometabolic medicine somewhere else. There's a drive now, because of the relationship between sleep apnea and these outcomes, to call it cardiorenal metabolic pulmonary disease.
My second question is there a combo drug in the making, combining GLP-1 with SGLT2 inhibitors?
Gosh, I think in India. No. But I don't know here. I'm not aware of that. Maybe.
Well, thanks for flying in, and thanks for making it, and thanks.